I'll make it in my 20 minutes. But I'll stand ready to be cuffed and walked away if necessary. So it's very difficult to talk about all of the different neurosurgical issues with Ehlers-Danlos syndrome. So I'm going to focus primarily on craniocervical instability, which I think is the most disabling of all of the neurosurgical problems. And then Rebecca also asked me to touch on tethered cord syndrome. I'm going to throw a few slides in as well on atlantoaxial instability. But when I think of headache in the Ehlers-Danlos patient, I think of craniovertebral instability and Chiari malformation and atlantoaxial instability, vertebral instability, pseudotumor cerebri, occipital neuralgia, temporomandibular joint syndrome, jugular venous occlusion, and other abnormalities of jugular flow, intracranial thrombosis, hypercoagulability, and migrainous TIAs, and now the whole array of neuroimmunological disorders. We're seeing PANDAS and neuropochettes, and of course, even tethered cord syndrome causes headache. But I'm going to focus on the craniovertebral instability. And patients with intracranial instability usually have a cervicomedullary syndrome. It's manifest by headache and neck and even face pain, double vision, memory loss, speech difficulties, word finding problems, dizziness, vertigo, hearing loss, tinnitus, difficulty chewing, swallowing, choking, clumsiness, tripping, unsteady gait, orthostatic intolerance, sleep apnea, numbness, paresthesias, weakness, tremors, and even urinary and GI issues. So if you have a patient with all of these problems, the only place in the body where all of these things come together in a nexus is in the craniocervical junction. So exemplary of the cervicomedullary syndrome is the Chiari malformation. And we don't have a pointer, do we? I think you can see the cerebellum, oh, right. The cerebellum pushing down through the skull base here, through the foramen magnum, causing pressure on the lower medulla and upper spinal cord, causing this syringomyelia down here. And the treatment for Chiari malformation has traditionally been simply a decompression with various bells or whistles. Now, the only problem is that if you follow these patients for more than 6 months, about 40 to 50% of them fail. And this is well established in the literature. Why is that? Grab, Mapstone, and Oakes, in their study of 50 children, found deformity of the brainstem. And in those children, they performed transoral odontodectomies and posterior fusions. Cahan found basilar impression. Menezes talked about the fulcrum effect of the odontoid pushing on the ventral brainstem. Gold talks about mechanical instability. And we also need to think about altered venous flow that Claire was talking about out of the brain, and altered compliance of the nervous tissue that affects its deformability and the ability of blood to flow through the nervous tissue. Recently, there have been a number of papers that discuss the complex Chiari and the importance of brainstem deformity. And in particular, the clivocervical angle, also known as the clivoaxial angle, and basilar invagination. So this is the clivus here, the center of the sphenoid bone, the skull base, and this is the axis. So this is the clivoaxial angle. And this is basilar invagination. You see here the odontoid pushing up into the brainstem, and this is a cause of sudden death in patients with deforming rheumatoid arthritis. Less so since the advent of Enbrel, but patients with basilar invagination often stop breathing and die. Menezes has talked about basilar invagination as a congenital abnormality. We see it in many of the genetic diseases like achondroplasia. And he talks about the importance of the clivus canal angle, which is the same, it's the clivoaxial angle. In this patient, the clivoaxial angle is 82 degrees, and this causes pressure on the brainstem here. You see that deformity. And this publication talked about intraoperative traction reduction to decrease that angle and decrease the deformation and pressure on the brainstem. And Goel, who has a very large series in India, talks about the importance of microtrauma from the odontoid pressing on the brainstem, and these repeated microcord injuries, which he believes are the defining factor in the entire pathophysiology that surround basal invagination. And he cites as contributory causes of this problem malnutrition, forceps delivery, vitamin deficiencies, degenerative changes. And that seems to be an excellent segue to Ehlers-Danlos syndrome, where we have a lot of degenerative changes in the discs and the osteo and the ligaments and bones. We see poor muscular conditioning. We see vitamin deficiencies in the majority of EDS patients. And these loose ligaments and weak muscles cause a floppy head syndrome. The head is sliding backwards and forwards over the spine, and this causes stretching and deformation of the brainstem, the upper spinal cord, the lower cranial nerves, the vertebral arteries, and of course on all of the ligaments. And this causes a chronic microtrauma to the brainstem and upper spinal cord. So the gold stand, well, let's go on here. Let me talk a little bit about the neurobiology of deformative stress, i.e. this microtrauma. What is it actually doing to the central nervous system? At an engineering level, stretching, when we simply flex the neck, bend the head forward, we cause our spinal cord and brainstem to stretch. In fact, if you measure the length of the cord between neutral on the left and flexion seen there on the right, there's a stretching or lengthening of the spinal cord of 17%, which comes precariously close to the 20% stretch at which the squid axon loses its function. And Professor Brieg, who did a lot of this thinking and work back in the 70s and early 80s, showed that this stretching of the spinal cord and brainstem is greatly increased by the presence of out-of-plane loading, such as from a disc or a retroflexed odontoid. Any pressure on the front, say, of the spinal cord here, pushing in, increases the tensile loading or the stretching of the cord, and also causes changes opposite the side of compression. And so then what is the pathological substrate, the histological substrate of what I'm talking about? And when I was doing my fellowship in London, England, at National Hospital for Neurology and Neurosurgery, the professor asked me to look at the spinal cord and brainstem of 10 patients who had died, sudden deaths, as a result of brainstem compression from the odontoid. And he said, what you'll find is ischemic change and necrosis, write it up, and then give me a paper in 2 weeks and we'll move on. But when we looked at the histology, we found these small silver staining balls that we later recognized as axon retraction balls, and that these, in fact, were not the result of ischemia, but were the result of stretching, deformity, deformative stress. And we published this work, but it was a little before its time. But a few years later, Pavlychuk and Maxwell Jafari published their seminal work on what happens when you stretch neurons. And this is very pertinent in the brain when you're thinking of diffuse axonal injury. But stretching neurons causes clumping and loss of the neurofilaments, which are the internal architecture of nerves, and of the microtubules, which are the highways for fast axonal transport. And you can see here here's a normal nerve up here, and then after stretching, there's clumping of these constituents. And if you take a mouse optic nerve and stretch it 20% of its length, you'll see that in 3 days, these axon balls show up, and at 10 days, there's a lot of nerve destruction and apoptosis and loss of nerves. Wolf showed that if you stretch a nerve, you deform the sodium channels, and this causes depolarization of the calcium channels and causes a massive influx of calcium, which is shown on the top here as the yellow color, the massive influx of calcium. And this influx is blocked by blocking the sodium channels with tetrodotoxin. And then Arendine showed that stretching is actually an epigenetic phenomenon to nerves. If you stretch a nerve, you cause upregulation of N-methyl-D-aspartate receptors. And we were talking about nitrous oxide over dinner. And these NMDA receptors are very important in learning and also in seizures, but they increase the vulnerability of the nerve to various nitrous oxide and free radical oxygen species. And they cause mitochondrial dysfunction, DNA fragmentation, and even apoptosis. And in this clinical study, we showed that in these patients with sleep apnea and who had this basilar invagination, you see right here, we performed transoral odontodectomy and removed the compression of the brainstem, and the sleep apnea went away. And we published that work in 1994. And then all of these concepts we put together in May of 2005. I rewrote this paper 10 times. It was finally accepted, but I think it's becoming well established now that the importance of deformation and stretch in the spinal cord. So then mechanical forces modulate gene expression and biochemical composition and directly affect neurons, making them more sensitive and more vulnerable to injury. So then we've been talking about floppy head syndrome. How do we measure craniocervical instability? How do we predict it? There are two surrogate measures of basilar invagination that we can use in the Ehlers-Danlos population. And one is the clivoaxial angle that I've discussed. Another is the Grab-Oakes measurement that I will discuss. So here's the normal clivoaxial angle between the skull base and the spine. It's 165 degrees. And if you get a protractor, you all can do this. Y'all is a southern term. It means you all. Okay. Inflection, the clivoaxial angle decreases to 155 degrees. On extension of the neck, it increases to 175 degrees. That's normal. Now, I think all of you would agree that this is abnormal, this clivoaxial angle. This is a patient I did not so long ago. And this angulation causes a deformity of the brainstem, and you can see how it would cause a stretching of the fibers in the back of the brainstem. You don't have to be an engineer or a neurosurgeon to see on the left, with a gentle bend of the brainstem, there's no stretching. But when you get a clivoaxial angle around 120 degrees, that there is a considerable stretch introduced into the brainstem. And this, we believe, causes many of the symptoms and findings in the EDS population. So the clivoaxial angle then is a surrogate measure of basilar invagination. And Kim, Riekate, Klopfenstein, and Sontag looked at a number of patients with Chiari malformation and found 10 that had failed. And in each of those 10, the clivoaxial angle was less than 135 degrees. That's that angle right there. And when they performed an intraoperative reduction of that angle and then a posterior fusion, all of the patients, or 90% of the patients, improved. And Kubota in Japan showed that a Chiari decompression failed to improve the syringomyelia, which commonly accompanies Chiaris. In all of those cases where the clivoaxial angle was less than 130 degrees. So there's something very important about the clivoaxial angle, and all of these authors have noted that importance, often using slightly different terms. And we published a paper on the deformative stress associated with abnormal clivoaxial angle and compared it with finite element analyses that was published in 2010. Now, another way to look at ventral, at this deformation and basal invagination is to look at the Grab-Oakes line. That's simply a line drawn from the basion to the posterior inferior aspect of C2, and then draw a perpendicular measurement. If that is 9 millimeters or more, then you have ventral brainstem compression. So every time that person bends his head down to look at his cell phone or computer, they're causing a microtrauma on the brainstem. Now, there's some other important measurements. Holy looked at 600 normal spine x-rays and said that the distance between the basion here and the odontoid should be usually about 5 millimeters. If that distance is more than 10 millimeters, then you've got instability. So that's that measurement there in green. It should be less than 10 millimeters. And Lee just did a line from the basion, that yellow line, to the midpoint of the C2 lamina, and the odontoid process should lay in front of that line. If the odontoid transgresses that line, you have instability. Now, the Harris measurement is particularly important. That's from the basion to this posterior axial line, and that measurement should be less than 12 millimeters or you have instability. But using this measurement allows us also to see if there's any translation between the skull and the spine. And so this is the Harris measurement then. One is between the basion and this posterior axial line, and another is between the basion and the odontoid. Now, so in the normal condition, in flexion and extension, and we do a lot of dynamic flexion extension MRIs. If you don't have one here, you need to get one. The odontoid process should lie right underneath the tip of the basion there, and that should pivot over the same point without moving backwards and forwards. And the evidence for that is legion. There are many authors who describe and who state that there is no horizontal translation between the skull and the spine. The skull should not be sliding back and forth on the spine. It should pivot. And the reason for that should be obvious. Any sliding is going to cause stretching of all the components. So here's a pathological stretch between flexion and extension. The skull is sliding backwards and forwards, in this case 5 millimeters. All right, there's one other measurement that I won't go into in detail, and that's the amount of rotation between the first two vertebrae. If normally when you turn your head to the side, all that rotation occurs at the level of C1 for the first 20 degrees, and for the next 20 degrees, C1 and C2 move together. And so when you turn your neck all the way to the right, say, C1 should rotate no more than about 35 degrees on C2. But if the first cervical vertebra, C1, rotates more than 40 degrees, you're starting to get into a danger area. Our threshold is about 44 degrees. At that point, the vertebral artery becomes kinked, and the blood flow through it becomes drastically diminished, and you start getting retrograde flow from the carotid circulation. And you can get all kinds of, posterior. That's not a comment on what I'm saying. You can get all kinds of neurological problems from that. take this off my 20 minutes. Yeah, yeah. Okay. All right. So now in the EDS population, we're measuring C1-2 rotation in every patient. In this patient, you can see there's a significant rotation such that the facet joints are almost dislocated. If someone just turned this person's head another 5 degrees, those two vertebrae would become dislocated, and there'd be a significant risk of death. So now I'm just going to quickly present some preliminary results on 22 patients with Ehlers-Danlos syndrome who underwent craniospinal fusion. These were consecutive patients undergoing fusion. They weren't selected, and in 2011, 2012. And so we identified 24 patients, 22 responded and filled out all the paperwork and whatnot. And all these results were taken by a third party. It wasn't me asking the questions. It was a researcher that they had not met. The 21 females, because it's usually women who present with the craniocervical instability. Now, these are all the symptoms that we saw in this patient, and you question the number of different systems involved. And here, there are headaches, fatigue, dizziness, muscle pain, weakness of the arms, joint pain, neck pain, balance problems. This is descending order of occurrence. Memory, night awakenings, numbness, walking problems, dysautonomic, hands and feet turning cold, leg numbness, visual problems, leg weakness, vertigo, hearing issues, speech, urinary frequency, GERD, swallowing, choking problems, nocturia, irritable bowel syndrome, tremors. Some of these tremors can get quite significant and look like seizures. Numbness in the back, sleep apnea, a lot of symptoms. And our indications for surgery were headache, significant headache or neck pain, 6 or 7, well, average 7 actually. Brainstem and spinal cord symptoms, obvious neurological deficits, and then radiological demonstration of ventral brainstem compression or basilar invagination. And so the patient's positioned prone. The head is in a head holder, and they're prepped and draped. We don't have to shave terribly much. This is actually a cadaver performing a suboccipital decompression on the left, and on the right, I'm drilling the spine, drilling holes in the spine to place screws. This is a little bit difficult because the screws have to lie within 1 millimeter of the vertebral artery. The bones tend to be very small, and the screw positioning has to be absolutely precise to avoid the vertebral artery. We have a CT scanner in the room, and so after I place the screws, I check it with a CT to make sure everything's perfect, and we've not had any vertebral artery injuries. Then I walk to the head of the table and perform an open reduction. And this is described by many authors, but basically I take the head in the head holder and perform a traction maneuver, and then a extension maneuver, and a posterior translation to bring the basion, the skull base, directly over the center of the odontoid. This is usually an iterative process. We take a lot of measurements, and we try to maximize all of the various angles and the optimal positions. And then, as you commented, we place these grotesque screws into the back of the head and spine in order to stabilize that relationship. And to make that permanent, we take bone from the rib cage and place it between the skull and the spine. After usually 3 or 4 months, the fusion is fairly complete, and the metal hardware becomes redundant. Our fusion rate's been about 99%. And here's the instrumentation, and then you can see the split ribs here on either side of the spine between the skull base, C1 and C2. And here's the wound 1 week after surgery, 1 month after surgery. And here's a young lady, a month out, she allowed me to use these pictures, a month after surgery, showing that she actually has fairly good range of motion despite the fact that we fused the skull to C2. Here's an illustrative case, 16-year-old girl, headaches, 50% truancy, progressive clumsiness, poor balance. She said, I know what to do, I just can't tell my body what to do. She had jerking motions in the legs. Her teachers really disliked her because they thought she was a behavior problem. She had weakness, spasticities, disordered sleep architecture. Of course, her studies were read as normal, but I think you all now, all of you all, can look here, and is this, you see how this odontoid is well behind the clivus, and I think you can see that that is not normal. And the clivoaxial angle was abnormal. So she had the fusion stabilization, is postoperative MRI. After surgery, her pain level went from 55 to 100, but the large number of brainstem symptoms that she had, there are 11 symptoms, went to 0. Her Kanofsky, functional index, performance scale index went to 100. Her quality of life index, the SF-36, went to above normal. She began cycling 14 miles every day. Her reading speed doubled. She's captain of the debating team, straight A's, went to college. Now, in this series of 24 patients, I said we got 22 patients participating. We said, looking back, would you still have that craniovertebral fusion surgery? And 68% strongly agreed, 25% agreed, 9% somewhat agreed, no one disagreed. Would you recommend that to a family member? And I think there's one patient that somewhat disagreed. My quality of life was improved by having the craniovertebral fusion surgery, and all of the patients agreed to some extent. Having this improved my symptoms, decreased my limitations. Again, there was agreement that there was improvement. Now, if we look at symptom by symptom, and I actually deleted many slides that looked into this in more detail, we saw improvement in vertigo. 92% of patients with vertigo improved, 82% of patients with headaches, balance 78%, numbness 76%, dizziness. All the symptoms in blue significantly improved, and the latter symptoms, which may have more to do with the other aspects of Ehlers-Danlos syndrome, did not significantly improve. These, we took this information at 2 years, and so in the course of the 2 years, there are many other things going on with those patients. But if you wanted to know what symptoms showed statistically significant improvement, it was the frequency and grade of the headache, neck pain, the dizziness, vertigo, walking problems, and balance problems. A headache improved p-value of 0.001. And you'll notice, by the way, that the headache does not go away completely. Red is before surgery, blue is after surgery. And we see an improvement in the headaches, but they haven't gone away completely. There's still more issues. Frequency of headaches decreased, p-value of 0.001. Average neck pain decreased to p-value of 0.005. And again, you see in red the neck pain before, 7 to 10. Afterwards, there's still neck pain, but it's not as bad. We looked at the Kanofsky Performance Status Scale, which Dr. Francomano discussed. 100 is normal, and 10 is you are dying. And 80 is you're able to go to work. And so of our group of 22, 14 improved at least 1 grade. 5 at 2 years showed no change. 3 showed worsening. And overall, the group improved from a Kanofsky scale of 59 to 75. There were no perioperative complications, but rib pain was present in almost every patient. 71% reported persistent rib pain after surgery, but the pain was usually fairly mild, 3, and patients were not too bothered by that. But we have altered our rib harvest technique to mitigate that. So concluding on this part, the kyphotoclivoaxial angle of 135 degrees and craniocervical instability with or without Chiari malformation result in a panoply of neurological findings. And reduction of the kyphotoclivoaxial angle and oxybate to C12 stabilization and fusion appear to benefit the patient. And headache, neck pain, dizziness, balance, and gait statistically significantly improved. A lot of the other symptoms are improved, but not with statistical significance. Now, I'm just very briefly going to talk about atlantoaxial instability. And I showed you this picture where C1 was about to dislocate off C2. And these patients have a very characteristic presentation of neck pain and headache, nausea, orthostatic intolerance, dysautonomia, pain with neck turning, pain over the C12. If you press them back here, it'll be painful and cause nausea. There's decreased pinprick sensation. They're typically hyperreflexic. They have dysdiadochokinesia. They improve with a neck brace and CT confirmation. The surgery, this is how I correct that. It's been a very successful surgery. And I love this diagnosis because it's much less surgery for the patient. I've had some patients go home from hospital one day after surgery, and we've not had any issues with this. Tethered cord syndrome seems to go along with craniovertebral instability. And the many types of tethering, I'm just going to mention briefly the type we see with EDS. It's a stretching of the spinal cord by the filum terminale. And it's, in the EDS population, it's a clinical diagnosis, not a radiological one, because you often don't see any significant radiological features. But the patients, especially the children, have weakness of the legs that's otherwise unexplained, low back pain, sensory loss, especially in the sacral dermatomes, and a neurogenic bladder confirmed by urodynamics. And we're looking for a large post-void residual, detrusor sphincter dyssynergia characteristic findings. And there's remote history of frequent UTIs, of bedwetting, toe walking as a child, or they may have been pigeon-toed, growing pains, leg cramps, sleeping with knees bent, flat feet, and keep in mind that tethered cord syndrome can cause paresthesias of the hands and also headaches. And of course, you have to rule out other causes of peripheral neuropathy. Now, I said that most cases of tethered cord and EDS don't have radiological findings, but they might have a fatty filum terminale, fat in the filum, or they may have a spina bifida occulta, loss of absent bone over S1, or they may have a terminal syringomyelia or a scoliosis. There are other features of tethered cord syndrome. And here's this big band here is the filum. It's usually, normally in the normal patient, it's about 0.5 millimeter in size. In an EDS with tethered cord syndrome, it's usually 1 to 2.5 millimeters. And when you cut that, it briskly retracts, and we've seen an excellent response in the patients. So we've not done a formal study. This is just an informal telephone survey from some research helpers. But we saw neurological improvement in 11 out of 13 patients, functional improvement in 10 out of 13, quality of life 8 out of 13, and improvement in pain in 11 out of 13. This one doesn't seem to make sense given that the pain was better, but there you have it. So every patient, with the exception of one, said they'd do the surgery again if they had the choice, would recommend it to a family member. the complications were really minimal, like an IV thrombosis, a urethritis, small PE. Over the last 4 years, I've had 2 pseudomeningoceles, one of which required me taking the patient back to surgery for a relatively small procedure. It's been a very safe procedure with no significant morbidity. So in conclusion, tethered cord syndrome is the result of tension of the filum terminale and stretching of the spinal cord. And in EDS, it's a clinical diagnosis, not a radiological one. In a well-selected patients, we see improvement. The published improvement is 85%. Amongst my patients, it's been more like better than 90%. So I'd like to acknowledge all the many people I've been working with, especially Dr. Francomano, who I think is one of the, anyone who knows her knows she is, she's done so much for Ehlers-Danlos syndrome, and she's so kind to every patient and their families and works tirelessly to help them. But everyone on this page has done a tremendous work toward this effort. Thank you for your attention. All right. Did I go over my 20 minutes?
One of the things I've learned is once you let a surgeon start, you're there till the end. Doesn't matter how much I make the patient move midway through. No, thanks very much, Dr. Henderson.
Okay.
Any questions, please?
Can you ask? Yeah. Yeah. Actually, my fellowship was in craniocervical. I've been doing this procedure a lot for over 20 years. And I think it's one of the best surgeries that I do in terms of the benefit to the patient. And the relative lack of morbidity. It's potentially a very dangerous procedure, but then so is driving on the Beltway. And so if you know the risks and you're diligent and careful, I mean, if you like your patient, then it seems to be relatively free from morbidity and high, very rewarding from my point of view. So,
of the patients that come to you, how many fulfill the criteria for surgical procedure? Like, I just want to get a sense of, because a lot of the symptoms seem to be what we discussed as the presenting symptoms. So, do you think that all patients?
Well, no, I think I see patients from all over the United States, and South America, and Europe, and Kazakhstan, I mean, everyone. So I think I'm getting the worst patients. And but if someone walks in and they're still at work, if they're able to work and function reasonably normally, then I don't think they're a good candidate for surgery. I think that actually they might well benefit from surgery, but I'm getting a little bit more conservative. But getting back to your question, I would guess that maybe 1 in 100 EDS patients needs this kind of surgery, but I don't know. We'd have to round up a lot of EDS patients and test them all, and I think that only the worst patients get diagnosed, and so my practice is very unusual. Most of my patients are out of state. And from around Washington locally, I mean, that constitutes maybe 10% of my practice. But people who actually come to me, I think I'll operate on probably, well, I haven't really added it up. But most of the patients who are sent to me are pretty severe to begin with. Anyway, yeah. I hope that answers your question.
Yes.
Yeah.
There.
Okay, yes.
When you're doing the tendon cord surgery and the cranial cervical stability test, which one do you do first in the hierarchy?
Well, I operate on the principle that if you do the worst one, the worst problem first, then see how they do. If they can function well enough with that, then that's all that they really need. I mean, I'd rather do just one surgery and that's it. Now, the reality is that a lot of the patients who've had the craniocervical surgery did need a tethered cord surgery, and I don't really know why. And which one do I do first? Again, I do the problem that's most severe at the time. Some people can barely walk or can't walk, and so I'll do the tethered cord first. But if they are having excruciating headaches and orthostatic intolerance and syncopal episodes and hand numbness and weakness, then I'll do the craniocervical stabilization first.
Do you notice any association between EDS and cervicomyelitis? Or with the patients with EDS, do you notice any family members also increase the incidence of cervicomyelitis? The last part is, if a patient has a cervicomyelitis, the patient with, let's say, EDS, will you consider the surgery to correct the problem?
Well, first, Ehlers-Danlos, of course, is autosomal dominant, and Chiari is very familial. So we often see Chiaris in many members of the family. We don't see as many cases with syringomyelia. I used to do more surgeries on syringomyelia about 10 years ago. But now I think that syringomyelia generally reflects a pathological process somewhere else. So if you have a Chiari and an abnormal clivoaxial angle, if you fix the Chiari in the clivoaxial angle, the syrinx will go away. And so that's how I handle most syrinxes. Or the syrinx may be from a tethered cord. If you have a syrinx in the lower thoracic spine, then look for a tethered cord syndrome. And fixing that will take the syrinx away. So to me, a syrinx is a marker for another pathological process.
I have a question in terms of autonomic function. Have you measured autonomic function before and after the surgeries? Or do you have any objective way to document the improvement in the autonomic function? Because I know these patients improve clinically. You stop having syncope, magically stop having the postural pressuric tachycardia. But have we measured objectively the autonomic function?
Well, the dysautonomia is multifaceted. You mentioned orthostatic intolerance and syncope, and there's also imbalance of the sympathetics and parasympathetics, and sometimes they talk about sweating, hyperhidrosis, and then chills and sweats, and I think that's dysautonomia, and then the Raynaud's phenomenon. And you're right, it would be we probably could establish some metrics for dysautonomia and measure it. That would be a very good thing to do. But we have not been doing that.
One of the simple things is using the paraparability, right? So which is a marker of cardiovascular autonomic dysfunction, right? So and we do the Holter monitor, right? So basically the Holter monitor before and after the surgery, right? So we can look at this imbalance, autonomic imbalance from some analysis that we use with our spec analysis. So it would be interesting to see
To put on a Holter monitor.
Yeah, before and after the.
Yes.